Now we are going to discuss intestinal obstruction. Intestinal obstruction. So first question is asked, what is the most common cause of large bowel obstruction? And it's the malignancy. So first question, most common cause of large bowel obstruction. Be careful, it's malignancy. It's the malignancy. Second question, most common cause of small bowel obstruction, and that is adhesions. So most common cause of small bowel obstruction, and that is adhesions. This is a common mistake in exam. Generally, the question is asked most common cause of large bowel obstruction, and the first option is adhesions, and most of the students mark adhesions. Be careful. In question, if large bowel obstruction is mentioned, you will mark malignancy. Small bowel obstruction is mentioned, you will mark adhesions. Now we are going to discuss first small bowel obstruction. Small bowel obstruction. So I told you, what's the most common cause of small bowel obstruction? Adhesions. What are the other causes? First is adhesions, which is most common. Is the most common. Second is the malignancy. Third is hernia, and fourth is Crohn's disease. It's in order. So most common causes adhesions, followed by malignancy, followed by hernia, followed by Crohn's disease. You remember adhesions? How to remember these three? The mnemonic is MHC. It's the MHC: malignancy, hernia, and Crohn's disease. Now, what's the cause of adhesion? The cause of adhesion is history of previous surgery. So any kind of intra-abdominal surgery can lead to adhesion. Question, in which surgeries there is maximum risk of adhesions? So maximum risk of adhesive intestinal obstruction is seen in pelvic surgeries, followed by lower abdominal surgeries, pelvic surgeries, followed by lower abdominal surgeries, followed by upper abdominal surgery. So you have to be very careful. Sometimes examples are given, like in surgery of or abdominoperineal resection or low anterior resection is there, appendectomy is there, cholecystectomy is there. So which one is having maximum risk of adhesions or adhesive intestinal obstruction? Is the low anterior resection, followed by appendectomy, followed by open cholecystectomy. So you have to see that which kind of surgery is being performed. Second question, which malignancy is associated with small bowel obstruction? So which malignancy? Generally, it is metastasis. Is the metastasis or peritoneal carcinomatosis? Is the peritoneal carcinomatosis. So whenever there is metastasis to small bowel or peritoneal carcinomatosis, this leads to small bowel obstruction. Now see what are the sequence of events in small bowel obstruction. See the clinical features. You can see this is stomach, this is the duodenum, and this is the jejunum. Now what is the problem here? Suppose here is the obstruction. If here is the obstruction, what will happen? The small bowel will start doing hyperperistalsis, and because of this hyperperistalsis, there is colicky pain. So question is asked, what is the first symptom? It's the colicky pain. So see, it is characterized by colicky abdominal pain plus multiple episodes of bilious vomiting, multiple episodes of bilious vomiting plus obstipation. What is obstipation? It's non-passage of feces and flatus, and it is also known as, the other name is absolute constipation. The other name is absolute constipation. So it's obstipation or absolute constipation. Now there are 2-3 basic things about the small bowel obstruction. It's simple to understand. See, if proximal obstruction is there, suppose obstruction is there in the duodenum, what is more common? Vomiting is more common. And if obstruction is terminal ileum, means in the distal part of small bowel, what is more common? Distension. So vomiting is more common in proximal obstruction, distension is more common in distal obstruction. Second question, since vomiting is more common in proximal obstruction, and that's why dyselectrolytemia is also more common in proximal obstruction. So 2-3 important points. See, in proximal obstruction, vomiting and dyselectrolytemia. Vomiting and dyselectrolytemia is more common, whereas in distal obstruction, distension is more common. There is distension. One feature. Now see, suppose here is the obstruction. If here is the obstruction, what is the problem? The proximal part of obstructed bowel is distended and the distal part is collapsed. Now what is going to happen in this proximal part of bowel? There is collection of fluid. And what is the other problem? There is secretion of fluid from the jejunum. Generally 2 to 3 liters of fluid is secreted from jejunum or small bowel. And third, there is swallowed air. This swallowed air is also not going to pass this obstruction. So what happens? Swallowed air is responsible for formation of air fluid levels. So here there is fluid secretion from small bowel or small intestine. This leads to third space loss. Third space loss means the fluid is going from vascular compartment into extravascular compartment, and because of this what will happen? There is a state of hypovolemia. One. Second, bowel is sensitive to stretch. So whenever there is stretch or distension of the bowel will start doing self-decompression, and this self-decompression is going to occur in the form of vomiting. So this leads to what? Vomiting. Second question is the air. Swallowed air is responsible. Swallowed air is responsible for air fluid levels. So question is asked, what's the major component? The major component of air is nitrogen in the air fluid level. So be careful. It's the swallowed air responsible for formation of air fluid level. So the major component is what? Nitrogen. After that, initially when the bowel is doing hyperperistalsis and we are going to auscultate the abdomen, there is hyperactive bowel sound. But in late stages, what happens? The bowel is exhausted. So at that stage, there is either sluggish or absent bowel sounds. So see, initially there is hyperactive bowel sound. Hyperactive bowel sound. In late stage, In late stage, it's either sluggish or absent. It's either sluggish or absent. So what is the main problem of this patient? At the time of presentation, patient is in state of hypovolemia. So what we have to do first? We have to resuscitate the patient first. Now see how we are going to start the management. So management, put 2 large bore IV cannula, 2 large bore IV cannula. Start IV fluids. What is the fluid of choice? Is the ringer lactate. Ringer lactate RL is the fluid of choice. So we started the resuscitation. After that we have to insert nasogastric tube. Why? For proximal decompression. Nasogastric tube for proximal decompression. One thing. Second, Foley's catheterization. Foley's catheterization. Why? For monitoring of urine output. Monitoring of urine output. One question is asked, what is the best clinical indicator of tissue perfusion? And the best clinical indicator of tissue perfusion is urine output. After adequate tissue perfusion, how much should be the minimum urine output? It should be 1 ml per minute. So two questions which are asked frequently. First, best clinical indicator. Best clinical indicator of tissue perfusion. And it's the urine output. It's the urine output. After adequate tissue perfusion, the minimum urine output should be 1 ml per minute in adults, and it should be 0.5 to 1 ml per minute in children. 0.5 to 1 ml per minute in children. Now see, when this much of urine output is there, then only we are going to send the patient for investigations. So questions are asked, which investigation? First question, what is the investigation of choice for diagnosis of small bowel obstruction or intestinal obstruction? Is the abdominal X-ray. Is the abdominal X-ray. In abdominal X-ray, there are two views. One is erect and the second is supine. Erect and supine. You must be knowing that erect is better for air fluid levels. Air fluid levels. Question, how many air fluid levels are normal? 3 to 5 air fluid levels are normal. Now supine, it's better for, this is better for site of obstruction. So it's better for site of obstruction. And if we are going to compare both, what, supine is better than erect. So overall, this supine view is better than erect. This question is frequently asked. So this is abdominal X-ray. After that, what is the role of CCT? Generally, CCT is used for high-grade obstruction. It is used for high-grade obstruction. For extraluminal, be careful, for extraluminal causes of obstruction, and specially used for the diagnosis of strangulation. So this is role of CCT. After that, what's the use of enteroclysis or small bowel enema in small bowel obstruction? This is frequently asked question. Enteroclysis is the investigation of choice for low grade intermittent small bowel obstruction. So generally this is partial intestinal obstruction, and enteroclysis is investigation of choice. Lots of questions are asked how on the basis of X-ray you differentiate whether this is jejunum, whether this is ileum, or whether this is colon or large bowel. So how we differentiate whether this is small bowel or large bowel, and second, how we are going to differentiate jejunum from ileum. Have a look. Imagine that this is abdomen, and in this abdomen you can see that this is stomach, this is the duodenum, this is the DJ, this is the jejunum, and after that this is the ileum. After that, see, this is what? This is the colon. This is the colon, this is the rectum, and this is anus. So this is the normal anatomy. On the basis of this normal anatomy also, you can easily crack the question. Now see, suppose this is the X-ray, and in this X-ray you can see a dilated bowel loop. That loop is located centrally, and this is the location. Simultaneously, it's having circumferential ring-like pattern. So on the basis of, can you see here, on the basis of this location itself, you can make out that this is jejunum. So dilated bowel loops placed centrally having circumferential ring-like pattern known as valvulae conniventis, it is suggestive of jejunum. Now see, if there is dilated bowel loops placed centrally, especially in the lower part of abdomen, which is featureless or characteristically characterless, can you see the location? So it's the ileum. Now third point, imagine if there is dilated bowel loops, presence of dilated bowel loops which are peripheral, can you see, peripheral, and it is wider in caliber, peripheral, wider in caliber, and there is presence of ostrations. So you can make out what? That this is large bowel, means colon. Third important point, we have to focus on the rectum. If there is gas in the rectum, it is suggestive of partial intestinal obstruction, and if there is no gas in rectum, it is suggestive of complete intestinal obstruction. So how we differentiate on the X-ray? Have a look. So here you can see there is dilated bowel loops, dilated bowel loops. Simultaneously, what else you can make out? There is circumferential ring-like pattern, and this circumferential ring-like pattern, this is known as valvulae conniventis. Valvulae conniventis. So this is circumferential ring-like pattern. So simple question, what is this bowel loop? This bowel loop is actually jejunum. So you can see this is placed centrally, dilated bowel loops placed centrally having circumferential ring-like pattern, and that is jejunum. What is the special feature of ileum? Again, ileum is also placed centrally. It is placed centrally and it is featureless. There is no special feature. So this is featureless or characteristically characterless. It's characteristically characterless. Third, how we are going to diagnose the large bowel obstruction. So in this picture, what you can see that these are the bowel loops. Can you see? There is presence of ostration, and here you can see that this is the transverse colon and this is the descending colon. You can see there is presence of ostration. So what is the difference between small bowel and large bowel obstruction? These are placed peripherally. There are lesser number of bowel loops. It is wider in caliber and there is presence of ostrations. So see, this is large bowel obstruction. So how we are going to differentiate it from small bowel obstruction? First, it is wider in caliber, placed peripherally. It is placed peripherally. There is ostrations, presence of ostration, and five loops are there. Lesser number of bowel loops are there. So this is how we can easily differentiate large bowel from small bowel obstruction. These questions are asked frequently. After diagnosis, we are going to manage the small bowel obstruction. See, the treatment depends on the cause. So how we are going to manage? Management. If the patients are having adhesions, how we are going to manage? We go for adhesiolysis. For adhesions, adhesiolysis. Second, if there is malignancy, for malignancy, we go for resection plus anastomosis. Resection plus anastomosis. If there is hernia, what we go for? In cases of hernia, we go for reduction, and in cases of Crohn's disease, we go for resection and anastomosis. Resection plus anastomosis. So this is how we are going to manage the cases of small bowel obstruction. After that, question is asked how you can differentiate between simple obstruction from strangulation. Now, what is the basic difference between simple obstruction and strangulation? In simple obstruction, there is mechanical obstruction with preserved blood supply. But in strangulation, there is obstruction with impaired blood supply. Now see the differences. In simple obstruction, what's the difference between simple obstruction and strangulation? Now see, this is the bowel. In this bowel, what happens? There is luminal obstruction. So there is mechanical obstruction, but blood supply is preserved. What happens generally in strangulation? Usually these are closed loop obstruction. So usually these are closed loop obstruction. Clear? So in this closed loop obstruction, what happens? One, there is obstruction. Simultaneously, there is impaired blood supply. So see, in simple obstruction, there is mechanical occlusion or mechanical obstruction with preserved blood supply. Preserved blood supply. These are generally seen in closed loop obstruction. This is generally seen in closed loop obstruction. And here the blood supply is compromised. So it is characterized by compromised blood supply. So whenever there is strangulation, there are signs and symptoms of strangulation. So what are the classical signs of strangulation? These questions are asked. So we are going to suspect strangulation if any patient of obstruction is going to develop what? Fever. There is tachycardia, there is leukocytosis. So the classical signs are fever, tachycardia, and leukocytosis. Now see, in cases of mechanical obstruction, what kind of pain is there? Since there is hyperperistalsis caused by bowel, so here usually we have colicky pain. But when this colicky pain becomes steady, constant, then we have to suspect that there is what? Strangulation. So in this case, there is constant non-crampy pain. Constant non-crampy pain. Okay. Generally, mechanical obstruction can easily be diagnosed by abdominal X-ray. So we can easily diagnose it by abdominal X-ray. But we discussed that for strangulation, what we require? CT. So here, for diagnosis, generally CCT is required. So this is the basic difference between mechanical obstruction and strangulation. Now we are going to discuss paralytic ileus. So what is paralytic ileus? Just break it, you will get the answer. So it is composed of two components. First, there is paralysis. So what happens? Paralysis means neuromuscular failure. And because of that, what? There is no peristaltic wave. And because of that, what? There is ileus. It means the food, the fluid, the contents are collected in the bowel. So what is going to happen in paralytic ileus? It is characterized by impaired intestinal motility. Impaired intestinal motility. So why this intestinal motility is impaired? It's due to failure of transmission of peristaltic waves. Failure of transmission of peristaltic waves. And what's the cause? It's because of neuromuscular failure. It's because of neuromuscular failure. So because of this, what happens? There is failure of transmission of peristaltic wave. So whatever the gas, whatever the bowel content is there, it will be collected in the bowel. And because of that, what happens? There is abdominal distension. Be careful. Since there is no peristalsis, what? The bowel sounds are sluggish or absent. And that's why, since there is no peristalsis or hyperperistalsis, it leads to only abdominal distension and discomfort. But colicky pain is characteristically absent. So because of this, what happens? There is accumulation of fluid and gas inside bowel, and this leads to abdominal distension. So this is the basic concept about paralytic ileus. There are multiple causes of paralytic ileus. What are the important etiological factors responsible? Have a look. Etiology. Etiology of paralytic ileus. You have seen these cases in surgery ward. So one of the most common causes, what? Abdominal operations or abdominal surgery. There is uremia, intra-abdominal sepsis, generally retroperitoneal hematoma or hemorrhage, mesenteric ischemia, dyselectrolytemia, and certain drugs which impairs bowel motility. One of the important drugs are opiates, and antipsychotics. Opiates and antipsychotics. So these are the etiological factors responsible for paralytic ileus. Now coming to clinical features. So I already told you that these patients are having abdominal distension, right? Because of this abdominal distension, what happens? There is discomfort. Because of this abdominal distension, since bowel is sensitive to stretch or distension, there is vomiting, and since there is failure of peristalsis or absence of peristalsis, so there is non-passage of feces and flatus, and there is absent bowel sounds, and non-passage of feces and flatus. Simple. So these are the clinical features of paralytic ileus. It's very easy to remember. How we are going to make the diagnosis? Generally, there is abdominal distension because of collection of gas and fluid in the bowel loops. So on X-ray, we are going to find out dilated bowel loops, sometimes with multiple air fluid levels. What's the treatment? Treatment is easy. We have to go for nasogastric aspiration. Nasogastric aspiration, restrict the fluid intake, oral fluid intake, until and unless bowel sounds are going to appear and patient is going to pass flatus. Simultaneously, whatever the underlying cause is there, we have to treat it. So see, diagnosis. These are the clinical findings. Diagnosis. Investigation of choice for diagnosis, obviously, is the abdominal X-ray, and the question is asked, what are the findings on abdominal X-ray? There is dilated bowel loops, there is multiple air fluid levels, and be careful, since there is no complete obstruction or there is no mechanical obstruction, usually there is presence of gas in the rectum. So this is very important finding. There is presence of gas in rectum. So there is presence of gas in rectum. So this is how we are going to diagnose it. Now coming to the management. First, nasogastric aspiration. Second, restriction of oral fluid intake until return of bowel sounds, and patient should start passing flatus. So patient should start passing flatus. Then only we are going to allow the patient orally. Simultaneously, treatment of underlying cause. What does it mean? Sometimes it's caused by dyselectrolytemia, you have to treat it. Sometimes there is sepsis, focus of sepsis, you have to treat it. Sometimes the drug is responsible, you have to stop or withdraw the drug. So this is how we are going to manage the paralytic ileus. I told you, abdominal surgery is one of the common cause of paralytic ileus. So if after surgery there is paralytic ileus, this is known as post-operative ileus. So this was asked in exam many times. Which organ is responsible for post-operative ileus? Now see, after surgery, earliest activity is seen in small intestine within 24 hours. Earliest activity is seen in small intestine within 24 hours. In stomach, the activity is seen within 48 hours. It is seen within 48 hours. And in colon, how much time it takes? Colon takes 3 to 5 days. Colon takes 3 to 5 days. So simple question is asked, which organ is responsible for post-operative ileus? Is the colon. Colon is responsible because it takes 3 to 5 days. So activity is seen in 3 to 5 days in colon. So it's the colon which is responsible for post-operative ileus. This question was asked in AIIMS. After that, second question, in small intestine, in which part earliest activity is seen? It's the jejunum, and in jejunum earliest activity is seen within 8 hours. So very important question. Earliest activity, it is seen in jejunum, and within how many hours? It is seen within 8 hours. So earliest activity is seen within 8 hours in jejunum. After that, question is asked, what is the difference between paralytic ileus and mechanical obstruction? Now see, in paralytic ileus, the basic difference is that there is absence of peristalsis. In mechanical obstruction, what happens? There is hyperperistalsis. So because of this hyperperistalsis, what's the problem? There is colicky pain. But colicky pain is typically absent in paralytic ileus. Second, in mechanical obstruction, if there is complete obstruction, what? There is absence of gas in the rectum. Second, in mechanical obstruction, since there is hyperperistalsis and you are going to auscultate the abdomen, what you are going to find? There is hyperactive bowel sound. And in paralytic ileus, since there is absence of peristalsis, what happens? There is absent bowel sounds. So see the basic difference between paralytic ileus and mechanical obstruction. So in paralytic ileus, what? There is absence of peristalsis. And because of this absence of peristalsis, there is no colicky pain. Simple question. There is no colicky pain. There is absent bowel sounds. Since mechanical obstruction is not there, what you might find? So there is gas in rectum. Now in mechanical obstruction, what happens? Since there is hyperperistalsis, so it is associated with hyperperistalsis. So because of this hyperperistalsis, what's the problem? First, there is colicky pain. There is hyperactive bowel sound. And third finding, in cases of complete obstruction, what? There is absence of gas. So there is absence of gas in rectum. So there is absence of gas in rectum. So this is how we can differentiate paralytic ileus from mechanical obstruction. Now we are going to discuss intussusception. So what is intussusception? Intussusception is telescoping of one segment of bowel into another. So see, this is one segment of bowel and this is going to enter into another. So this is telescoping. So it is characterized by telescoping of one segment of bowel one segment of bowel into another. Generally, it's more common in children. Which particular age group? It is seen in 4 to 10 months of age. 4 to 10 months. Question is asked, what's the most common type? Most common type of intussusception is the ileocolic. Ileocolic followed by ileocolic, ileocolic followed by ileal, followed by colocolic. So be careful, it's ileocolic followed by ileocolic followed by ileal followed by colocolic. This is the latest question. It's the latest question. So the most common type is ileocolic and this is the sequence. Another question, most common type of intussusception in adults is the colocolic. So next question, what is the most common type in adults? The most common type in adults is the colocolic. Colocolic. Now see, what are the parts of intussusception? This is the intussusception. So here you can make out that one loop is going to enter into another. This incoming segment, this is the incoming segment and it's known as intussusceptum. What is this? This is the neck. It's the neck. What is this? This is the apex. And the accepting segment or the recipient is intussuscipiens. So this is the recipient and it's known as intussuscipiens. So question, how to remember? Recipient is suscipiens. How to remember? The recipient is suscipiens. That's why the recipient is intussuscipiens. This question was asked long back in one exam and the question was, out of these four, which part is most prone to gangrene? So it's the apex. Apex, which is most prone to gangrene. It's most prone to gangrene. After that, second question, this is the outer layer, this is the middle layer and this is the inner layer. So out of 1, 2, 3, outer layer, middle layer, inner layer, which one is most prone to gangrene? So it's the middle layer. It's the middle layer. So it's the middle layer which is most prone to gangrene. And which part exactly? It's the apex. Now see, I told you that it is more common in children. What's the age? 4 to 10 months. This is the age of weaning. So what is the hypothesis? That during 4 to 10 months of age, what? Weaning starts. And during weaning, what is the problem? There is increased risk of infections. Which particular infection? Especially rotavirus diarrhea. And because of this rotavirus diarrhea, what's the problem? There is Pierce patches hypertrophy. Pierce patches hypertrophy. And because of this Pierce patches hypertrophy, what? Ileum enters into colon, leading to intussusception. So ileum enters into colon, leading to intussusception. And obviously what kind of intussusception? It's the ileocolic. See this diagram? So in this diagram you can make out what? That this is the ileum and this ileum entered into colon. Why? Because of Pierce patches hypertrophy. So this is the most common type of intussusception. In majority of cases there is no cause. It means it's idiopathic. And this is the hypothesis. Now see, in certain cases, there is some kind of anatomical abnormality, and because of this anatomical abnormality, one loop enters into another. So question, what's that most, this anatomical abnormality is known as lead point. So question is asked, what's the most common lead point responsible for intussusception? So question, the most common lead point responsible for intussusception, and it's the Meckel's diverticulum followed by polyp. After that, there was another question in AIMS. What's the most common tumor responsible for intussusception? So question, most common tumor responsible for intussusception in children, it's the lymphoma. In children, it's the lymphoma, because lymphoma is the most common small bowel tumor in children, and in adults it's the villus adenoma. So in children it's the lymphoma, and in adults it's the villus adenoma. So these are the questions which are frequently asked. Now what are the clinical features? Simple, it's very easy to understand. See, since one loop of bowel entered into another, so can you see this? Here there is obstruction, and if there is obstruction, what are the symptoms? There is colicky pain, there is multiple episodes of vomiting, but what is the good thing? This attack lasts for 3 to 4 hours, and then the bowel loop comes out. Then patient becomes asymptomatic. So I told you it is more common in children age 4 to 10 months. So the mother is going to describe this problem that, sir, at the time of attack, child cries a lot. Child pulls legs towards abdomen because of colicky pain. At the time of attack, there are multiple episodes of bilious vomiting, and mother tells you that if 3-4 attacks are there, child is going to pass little amount of stool mixed with blood, and that is known as what? Red currant jelly. So all these are important points related to intussusception. Have a look. Clinical features. Child cries a lot. During attack, child cries a lot. Pulls legs towards abdomen. There is vomiting, so multiple episodes of bilious vomiting. There is bilious vomiting. Patient is asymptomatic in between attacks. Asymptomatic in between attacks. And after multiple attacks, what? Passage of small amount of stool. Small amount of stool mixed with blood. Mixed with blood. This question is frequently asked. It's having red currant jelly appearance. So this is having red currant jelly appearance. Now see, when the attack is there and we are going to palpate abdomen, what are the findings? See, so you can see the finding is something like this. This is the site of intussusception. So here you can find that there is sausage shaped mass. Simultaneously, this is the right iliac fossa and this will be empty. So what you are going to find, there is sausage shaped mass. Sausage shaped mass in lumbar region, and you can see that there is empty right iliac fossa. Empty right iliac fossa, and this empty right iliac fossa, it's known as what? It's known as sign of dance. Sign of dance. Question is asked, how we are going to diagnose it? The condition which is both diagnostic and therapeutic. Now see, this is the intussusception. Clear? So which investigation is both diagnostic and therapeutic? Suppose we are giving enema. Can you see? If we are giving enema, this enema is doing the positive pressure or exerting positive pressure on this loop, and what will happen? This bowel loop will come out. So it's the enema which is both diagnostic and therapeutic. And be careful, in enema is the air enema which is preferred over barium enema. So very important point. Enema, it is both diagnostic, and therapeutic, and it's the air enema which is preferred over barium. So it's the air enema which is preferred over barium. Now see, if we are giving air enema and what this condition resolve, we are going to discharge the patient, and again if there is recurrence, what we have to go for? Repeat air enema. Again there is recurrence, repeat air enema. It's the third recurrence which is an indication for surgery. So management, air enema, and for recurrence, repeat air enema. For recurrence, repeat air enema. Question: third recurrence is the third recurrence which is an indication for surgery. So it's the third recurrence which is an indication for surgery. Indication for surgery. Now question, which surgery? See, this is the part of ileum and cecum ascending colon which is involved in intussusception. So we are going to remove this part of the ileum and colon. And after removing this part of ileum and colon, we are left with ileum and transverse colon. So what kind of anastomosis? Iliotransverse. So surgery is ileocolectomy with iliotransverse anastomosis. So surgical treatment is the ileocolectomy plus iliotransverse anastomosis plus iliotransverse anastomosis. So this is how we are going to treat the intussusception. Lots of questions are asked about various radiological signs seen in intussusception. So what are the radiological signs? Seen in intussusception? See the signs seen on X-ray first. So on X-ray, there is target sign, and there is meniscus sign. There is target sign and there is meniscus sign. After that, on barium enema, this is very important. There is claw sign, and there is coiled spring sign. Claw sign and coiled spring sign. After that, what are the signs seen on ultrasound? On ultrasound, again, this is important. There is target sign and there is pseudo kidney sign. There is target sign and there is pseudo kidney sign. So these are the signs asked. Now see how it looks like. So here on this barium enema, you can see what? That this is the claw sign. And why there is claw sign? Can you see? This is the bowel loop. Because of this bowel loop, entry into another bowel loop, this appearance is there. And what is this investigation? Obviously, can you see? This is what? This is the barium enema. So this is claw sign. And in this picture, you can see this one loop entered into another. So this is the lining of inner loop. And it appears like what? Coiled spring. So the name of this sign The name of this sign is what? It's the coiled spring sign. So claw sign and coiled spring sign, both of these are seen on barium enema. Now we are going to discuss pseudo obstruction. Pseudo obstruction. So it means it's not true obstruction, it is pseudo obstruction or false obstruction. So actually there is no mechanical obstruction, but patient might be having signs and symptoms of obstruction. So it is of two types. First, idiopathic colonic pseudo obstruction. What's the name of idiopathic colonic pseudo obstruction? It's known as Ogilvie syndrome. This is frequently asked question, Ogilvie syndrome. And after that there is secondary pseudo obstruction. Secondary pseudo obstruction. So obviously in secondary pseudo obstruction there are certain causes because it is secondary to certain factors. So what are those factors leading to pseudo obstruction? Hypothyroidism, uremia, dyselectrolytemia, retroperitoneal hematoma or hemorrhage, chronic visceral myopathy, Parkinson's, and drugs which impairs the bowel motility like opiates and antipsychotics. So it's easy to understand. You must be knowing that there are two systems which are going to control the peristalsis. One is parasympathetic. Parasympathetic is going to promote peristalsis, and another is sympathetic. Sympathetic system is going to inhibit peristalsis. So in pseudo obstruction what happens? There is sympathetic overactivity, and since there is sympathetic overactivity it leads to inhibition of peristalsis. Be careful, I said inhibition of peristalsis, not the absence. So since there is inhibition of peristalsis, what? Bowel sounds will be present but it will be sluggish. So what is the etiopathogenesis here? In this case there is sympathetic overactivity. And because of that there is impaired peristalsis, and because of this what will happen? There is colonic distension with air. So there is colonic distension with air. Simple. So in this case also, since there is inhibition of peristalsis, and because of inhibition what happens? Pain or colicky pain is not a feature. Since there is colonic distension with air, here there is abdominal distension, and that leads to abdominal discomfort. So see, what are the clinical features? So these patients are having abdominal distension, and this abdominal distension leads to discomfort. Bowel sounds, be careful, these are present but it's sluggish. How we are going to diagnose? It can be diagnosed easily by enema. And on enema, what? There is dilated large bowel or colon. How to manage? It's easy. In this case, you can see that there is sympathetic overactivity. So which drug we are supposed to give here? Parasympathomimetic, which is going to stimulate the parasympathetic system so that there is return of normal peristalsis, and after that patient passes massive amount of flatus and patient is relieved. So question, what is the drug of choice? Is the neostigmine. Is the neostigmine, and generally it's given IV. You know that this is parasympathomimetic. So this is given IV. It's a parasympathomimetic, and generally within 3 to 10 minutes, patient passes massive amount of flatus and patient is relieved. But what is the problem? Since it is parasympathomimetic, we have to rule out cardiovascular contraindications, and since it is going to promote peristalsis, we have to rule out acute obstruction. So what are the precautions? Rule out cardiovascular system contraindications and rule out acute obstruction. Now suppose if we are not able to rule out cardiovascular contraindication or acute obstruction, or there is some cardiovascular contraindication, at any cost what we are supposed to do, we have to take out the AF from colon. So how we are going to take out the AF from the colon? Can you see? We have to insert a tube. So we are going to insert a tube. So which tube? So we are going to insert the flatus tube, and via this flatus tube, what slowly air will be going out. So if these contraindications are there, or we cannot rule out the precautions, we are going to insert the flatus tube. So in these cases, flatus tube insertion. So flatus tube insertion. So this is how we are going to manage the pseudo obstruction. Now we are going to discuss large bowel obstruction. Large bowel obstruction. So the first question is asked, what is the most common cause of large bowel obstruction? The most common cause of large bowel obstruction is malignancy. It's the malignancy. Second question, what is the most common site of large bowel malignancy? It's the rectum followed by sigmoid. So most common site of large bowel malignancy is the rectum followed by sigmoid. Third very important point, that adhesions are rarely responsible for large bowel obstruction. Very important point, adhesions. These are rarely responsible for large bowel obstruction. Now, what is the presentation in large bowel obstruction? Just have a look. See, this is large bowel. This is rectum, this is anal canal, and this is ileum. Now see, here is the malignancy. Suppose malignancy is in the sigmoid colon. So if malignancy is there in the sigmoid colon, because of this there is obstruction. Now see, this valve is IC valve, and here there is unidirectional flow. So from ileum the content is going into cecum, but not the vice versa, because generally the valve is competent. So whenever this obstruction is there, can you make out that it's a type of closed loop obstruction? So this is a type of closed loop obstruction. So large bowel obstruction is a real emergency because it's a type of closed loop obstruction. First difference. Second difference, since there is competent IC valve here, abdominal distension is marked, not the vomiting. And third, the pain is perceived in the lower abdomen. So see the clinical features and characteristic features. It is characterized by colicky abdominal pain, especially in the hypogastrium or in the lower abdomen, plus abdominal distension, plus absolute constipation, also known as obstipation. Obstipation, also known as absolute constipation. These are the findings. I told you here there is abdominal distension, not the vomiting. Second, it's a type of closed loop obstruction. Since it's closed loop obstruction, it's a real emergency. It's a real emergency. And that's why surgery should be done as early as possible. So in this case, surgery should be performed as early as possible. See, at the time of presentation, the management is similar to small bowel obstruction. Means we have to put 2 large bore IV cannula, we have to start IV fluids, we have to insert the Rice tube, we have to insert the Foley's catheter. When the urine output is 1 ml per minute at least, we are sending the patient for investigations, and on X-ray, when the diagnosis is confirmed, we are going to proceed further. Now, how the management is different from small bowel obstruction? First, in majority of cases, malignancy is responsible. And since malignancy is responsible, what we have to go for? Resection and anastomosis. And I told you that in GI malignancies, usually how much margin is taken? 5 centimeter. So we take 5 centimeter margin and we go for resection and anastomosis. See, if the patient is having right colonic malignancy, in this case we go for resection, and since right colon is resected, we go for ilio transverse anastomosis. When the patient is having sigmoid malignancy, if the patient is having sigmoid malignancy, in this case either we go for sigmoidectomy plus colorectal anastomosis, Second option, we go for total colectomy plus ileorectal anastomosis, or we go for Hartmann's procedure. And if there is malignancy in the middle or lower part of rectum, mid or lower rectum malignancy, in this case we go for defunctioning colostomy followed by chemoradiation, followed by tumor resection and colostomy closure. This is how we are going to manage. Now we are going to discuss in detail how we are going to manage sigmoid malignancy and rectal malignancy, because these two are commonly asked. Have a look. So this is the colon. This is the descending colon. This is the sigmoid colon. This is the rectum, and this is the anal canal. Now have a look. If the malignancy is here in the sigmoid colon, first option, since the length of sigmoid colon is 30 cm, we can go for what? Sigmoidectomy. So we go for sigmoidectomy. And if we are going for sigmoidectomy, what kind of anastomosis is done? Colorectal. Because from top we are left with colon and from bottom we are left with rectum. Colorectal anastomosis. Second option, if this patient is having colonic ischemia, suppose here is the obstruction and patient presented late. On laparotomy the colon is papery thin. Because of that, what? I'm going to resect the whole colon. So can you see, in this case, almost whole colon is resected. So this is total colectomy. From top, we are left with ileum, and from bottom, we are left with rectum. So what kind of anastomosis? Ileorectal. So this is the total colectomy plus ileorectal anastomosis. Third situation, when the patient is elderly, can you see, we are going to perform the sigmoidectomy. So since we perform the sigmoidectomy, after that, can you see what we are left with? We are left with descending colon and rectum. So in this case, we are going to take out this colon as colostomy, and we are going to close the distal part of, we are going to close the rectum as the stump inside. So rectum is closed and left inside, and the colon is taken out. So this is Hartmann's procedure. So what are the components of Hartmann's procedure? Hartmann's procedure. What are the components? First, sigmoidectomy. Second, descending colostomy. And third, closure of rectal stump. Is the closure of rectal stump. So it's the closure of rectal stump. So these are the components of Hartmann's procedure. Generally, the patient in whom anastomosis is difficult, where the chances of anastomotic leak are higher, we are performing Hartmann's procedure. So this Hartmann's procedure is performed for sigmoid malignancy in elderly. It is performed for sigmoid malignancy in elderly. This is one question. After that, whenever there is malignancy in the middle or lower part of rectum, what surgery we are going to perform? See. Here also you can see that this is the large bowel, colon. This is the descending colon. This is the sigmoid colon. And this is the rectum. This is the anus. Now see, whenever the malignancy is located in the middle or lower part of rectum and it leads with, or patient presents with obstruction, since it's an emergency, we are just going to perform defunctioning colostomy or loop colostomy so that only obstruction is relieved. Later, when the obstruction is relieved, since malignancy is here, we are sending this patient for chemoradiation. So after defunctioning colostomy, first we perform defunctioning colostomy. After this defunctioning colostomy, we send the patient for chemoradiation. When the tumor is downstaged, it is followed by tumor resection. Plus colostomy closure. So tumor resection plus colostomy closure. So this is how we are going to perform the treatment of middle or lower part of rectum when patient presents with obstruction. Next is volvulus. So first question, most common site of volvulus is the sigmoid colon. Generally, it's anti-clockwise, but be careful, it can be both anti-clockwise as well as clockwise. So see, if a question is asked that sigmoid volvulus can be clockwise, anti-clockwise, both none, obviously it is both anti-clockwise as well as clockwise, but more commonly it's anti-clockwise. Now see how this volvulus occur. It's easy to understand. These patients are having long narrow mesentery. Now see, this is the sigmoid colon, this is the rectum, this is the anus. This patient is having long narrow mesentery. One problem. And the second problem, this sigmoid colon should be loaded with fecal matter. So when this sigmoid colon is loaded with fecal matter and it's having long narrow mesentery, what happens? Twisting occur, and this twisting is known as what? Volvulus. It means constipation is a risk factor, and anything which can lead to constipation in the patients who are having long narrow mesentery, that increases the risk. So see, predisposing factors. What are the predisposing factors? So first, old age. Second, hospitalized patients. Third, mentally impaired patients. And fourth, intake of drugs. Which drugs? Same, intake of opiates and antipsychotics. So intake of opiates and antipsychotics, all these are going to increase the risk of constipation, and these are risk factor for volvulus. Now what is the problem? See, if sigmoid is going under volvulus, since sigmoid is involved in the volvulus, because of that twisting will occur, and if twisting will occur, this leads to closed loop obstruction, and because of this closed loop obstruction, patient will present with large bowel obstruction. See, in this patient, this is the problem. You can see this is the sigmoid colon, and this kind of torsion is going to occur. So when in the sigmoid colon this kind of torsion occurs, it leads to closed loop obstruction, and since large bowel is involved, patient comes with signs and symptoms of large bowel obstruction. So see, clinical features. It's a type of closed loop obstruction, and patient comes with signs and symptoms of large bowel obstruction. Obviously, what is the investigation of choice for diagnosis? It's the X-ray abdomen. And whenever we are sending the patient for X-ray, see what is the finding. So here you can see what's the problem here. You can see that this is the sigmoid volvulus. So here you can see there is involvement of sigmoid colon in the volvulus. So this is the sigmoid volvulus. Can you see? This is the volvulus. So in this case, if we are going for X-ray, what kind of appearance is there? You can see there is coffee bean sign. So first question, there is coffee bean sign. Second, you can see that there is bent inner tube. So here there is bent inner tube, bent inner tube. And third, you can see this sign. What is this? This is omega sign. So on X-ray, third is omega sign. So be careful, all these signs are seen on X-ray. These signs are seen on abdominal X-ray. There are certain important signs which are also seen on barium enema. So on barium enema, what are the signs seen? So on barium enema, there is bird beak sign. Bird beak sign. There is ace of spades sign. Ace of spades sign. And third, there is bird of prey. Bird of prey sign. So these are the signs seen on barium enema. So here you can see that this is what? This is bird beak sign. Bird beak sign. In sigmoid volvulus on barium enema, two questions are asked. One, bird beak sign on barium swallow. It is seen in achalasia cardia. And bird beak sign on barium enema, it is seen in sigmoid volvulus. Since it's an emergency and it's a large bowel obstruction, first what we try to perform colonoscopic detorsion. So now see, what's the management? Management of sigmoid volvulus. In this case, we perform colonoscopic detorsion, followed by elective sigmoid colectomy. So we perform colonoscopic detorsion followed by elective sigmoid colectomy. So what we do basically, with the help of colonoscope, we detors the colon, sigmoid colon. So we convert emergency elective situation, and after that, after 3 days, we perform elective sigmoid colectomy. So this is having best results and this is the treatment of choice. Next is cecal volvulus. First of all, it's a misnomer because in this volvulus, mainly cecum, not only cecum, ascending colon is also involved. So it's a misnomer. The correct term should be cecocolic volvulus. The correct term should be cecocolic volvulus. Now see the problem here. You can see that this is ascending colon, this is the cecum, and this is the ileum. In this volvulus, some part of ileum, cecum, as well as ascending colon is involved. So here, what's the problem? See, after volvulus, the shape is something like this. Clear? This is ileum, this is the cecum, and this is the ascending colon. Clear? Now, in this case, relatively patients are younger as compared to sigmoid volvulus. What are the predisposing factors? It's very easy to understand. See, generally cecum is fixed. Anything which can make cecum mobile is a risk factor. Now see, in multipara patients, there is release of hormone relaxin which relaxes the ligaments. So, ligaments are relaxed and cecum becomes more mobile. History of previous surgery in which the ligaments are divided and cecum becomes mobile. Third, in malrotation, the cecal position is abnormal and it is not fixed. And fourth, any distal obstructive lesion in colon causes load on the cecum. These are the predisposing factors. So have a look. What are the predisposing factors? First, multipara patients. Second, history of previous surgery. Third, malrotation is the malrotation, and fourth, distal obstructive lesion. Distal obstructive lesion. Now there is a simple question. Since the torsion starts from ileum, it starts from ileum. Simple question is asked that these patients present with signs and symptoms of small bowel obstruction or large bowel obstruction. Here, so you can see that here patients come with or present with signs and symptoms of small bowel obstruction. So be careful here. Patient will be having colicky pain, multiple episodes of bilious vomiting, non-passage of feces and flatus. Again same, how we are going to make the diagnosis. Investigation is same. X-ray abdomen. And on this X-ray abdomen, this is the finding. So you can see this is the finding on X-ray abdomen. And what is the shape? Can you see here? This is known as kidney bean sign. So you can see this is kidney bean. So on X-ray abdomen, there is kidney bean sign, and there is comma shaped cecum, gas filled cecum. It looks like comma. This is important. Comma shaped cecum. So comma shaped cecum. How we are going to treat it? See, it's very difficult to manage this patient conservatively because you cannot detoss the cecal volvulus. So see, this is the colon, this is the ileum, this is the transverse colon, this is the descending colon, this is the sigmoid rectum anus. What is involved in the volvulus? That part of bowel should be removed. So can you see? We are going to remove ileum. We are going to remove cecum ascending colon. So this part of bowel is removed. So I am going to perform ileocolectomy. And after performing ileocolectomy, what I am left with? From below, I am left with ileum. From above, I am left with what? Transverse colon. So what kind of anastomosis? Ileotransverse. So the treatment is ileocolectomy. Is the ileocolectomy plus ileotransverse anastomosis. Ileotransverse anastomosis. There is another condition which is asked frequently, and that is known as cecal vesicule. Is the cecal vesicule. Now see what happens in cecal vesicule. This is cecum, this is ascending colon. So you can see this cecum is going to fold anteriorly in the cephalad direction. So when cecum folds anteriorly in the cephalad direction over fixed ascending colon, this is cecal vesicule. And because this is intermittent condition, so what happens? It leads to chronic intermittent intestinal obstruction. Now we are going to discuss cecal vesicule. So what happens in this cecal vesicule? In this case, cecum folds here, cecum folds in a cephalad direction. Where exactly? Anteriorly over fixed transverse, anteriorly over fixed ascending colon. Now see, suppose this is the cecum and this part is ascending colon. So what happens here? Cecum is a bit mobile, ascending in this particular condition. So what happens? Can you see? There is anterior fold in the cecum. So cecum is going to fold in a cephalad direction anteriorly over a fixed ascending colon. Because of this, what will happen? When the cecum is going to fold like this, what happens? There is intestinal obstruction. But see, this is what? Temporary. So what happens? Over a period of time, it resolves spontaneously. So whenever this turning occur or vesicule occurs, patient is going to have the abdominal pain. So patients are usually having intermittent episodes of abdominal pain. So what are the clinical features? It leads to intermittent episodes of abdominal pain. And what's the cause of this abdominal pain? The cause of this abdominal pain is obviously intermittent cecal obstruction. Intermittent cecal obstruction. Okay, and what is the good thing? That it resolves spontaneously. So usually it resolves spontaneously. So these are the questions which are commonly asked about cecal vesicule.